For the next lecture, I would like to call upon stage Dr. Amita ma'am. She would be making us understand painful bladder syndrome.
So you can hear me. Painful bladder syndrome or bladder pain syndrome, these are the synonyms. But the thing is that, yes, I am having only 10 minutes to, usually we do a kind of complete CME or workshops to make you understand. So I am just giving you a glimpse of the thing. So as you understand with the first slide, that's very confusing disease because it is the diagnosis of exclusion. So if we talk about pathophysiology, we all know what is the common, that there is a damage to the gag layer. So gag layer, that is glycosaminoglycan layer inside the bladder. The damage to the epithelium I have written. So that's the gag layer which is getting damaged, and because of that, your own urine, which is quite toxic, acidic, you normally you don't feel that urine, but because of this damage, that urine is getting penetrated inside the wall, and it is actually because of that leakage, it is causing inflammation, mast cell activation, immunostimulation, C fiber activation, and this is responsible for most of those symptoms of frequency, urgency, discomfort, all these things. So look at the etiology. The whole lot of etiology which can cause this insult, that could be autoimmune, that could be some chronic infection, repeated infections. It could be neurogenic, as have been explained by Dr. Diksha, that there could be many things for the neurogenic bladder. The pathology is not there, but sequelae would be in the form of bladder pain syndrome, or any trauma, or even the episodes of overdistension. So any insult to that inside lining of the bladder. So you can see this slide. It's just to show that how much work has been done on this disease all over the world. There are so many guidelines which were released one by one. So you can see yourself on the slide that there are so many guidelines. It starts from the Japanese, because it was thought first in Japan. It was found that European, American, and blah, 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 even the latest one, the Canadian RCOG. We have our own guidelines. 2017, we formed our own society with the name of Global Interstitial Cystitis Bladder Pain Society, GIPS. And I invite you all to be a member if you want to learn this disease. And we issued our own guidelines depending on the our scenario. So we are having everyone, physiologist, physiotherapist, urologist, gynecologist, everyone, and I myself are the part of the core member society. So the thing is that somebody will think that what is interstitial cystitis if everything is bladder pain syndrome. So why now we use this terminology? Because only a few subset of patients might have that particular signs of interstitial cystitis, those histological or cystoscopic features, which I will let you later on. Sometimes there would be absolutely normal looking epithelium. You won't find anything like any inflammation or something, like we see in the last case of cystoscopy. That doesn't mean that patient is not having bladder pain syndrome, because it is the diagnosis of exclusion. So known prevalence, we don't exactly, we don't know what is the exact prevalence, especially in our place India, but it is found more prevalent in the females, and the female to male ratio is around 5:1. Now coming to the definition part, it's very simple. Pain or discomfort in lower abdomen and or urogenital area of more than 3 months duration. The duration part, you can find different definitions at different parts of the world, and you can see that sometimes it is written 6 weeks, sometimes it's 6 months. We at GIPS decided it to be at 3 months. Why? Because it will not only, prevent the overdiagnosis, it will also prevent the, that we are not able to diagnose, because our patients are very poor in follow-up. So 6 months is not good. So 3 months is better. Other part of the definition, that this pain is worst on full bladder. That's very important, along with one or more lower urinary tract irritative symptoms like frequency, urgency, and nocturia, with or without standard stigmata of cystoscopy, as I explained to you, provided another discernible pathology likely to cause these symptoms has been excluded. Diagnosis of exclusion. And the most important thing is UTI. So location of pain. As you can see that Sometimes patient will come to you not particularly that she is having pain in bladder. She will say that probably it's lower abdomen or perineum, vulva, even clitoris, penis, inner thighs, lower back or anus, because pain could be referred as well. And then in the history itself, you have to rule out all those disorders which can have these similar kind of symptoms, like overactive bladder, frequency urgency could be there, irritable bowel, pelvic pain, urinary stone, all these things. It's written there. You can find the literature everywhere, but I need to point out some particular diseases which are important to differentiate, like overactive bladder. So how to differentiate between that? In overactive bladder, patient will void to avoid incontinence. So she will give history that there is a fear of leakage if she is not voiding in time. But with this, there is no fear of leakage. With bladder pain syndrome, there would be patient will void because she wants to, avoid that painful sensation once the bladder is full. So she will go, it would be a forced frequency. How to differentiate between, intestinal tract problems like IBS, patient will have more gastrointestinal symptoms if it is there. If it is mainly related to the menstrual cycle, you have to rule out endometriosis in these patients. And of course, there could be differential diagnosis like dyspareunia, vulvovaginitis, and vulvodynia. So you have to very careful before diagnosing these disease. You can even think of etiology depending on the history. If patient having other allergy disorders, probably the etiology is allergic. If patient is having pelvic floor spasm, voiding dysfunction, it could be pelvic floor dysfunction. You have to see the any recent change in diet. Many things you can see. Burning character can show that probably it could be neuropathic. And these are the disorders: fibromyalgia, migraine, mental stress, like patient taking a lot of type A personalities, irritable bowel syndrome, depression, panic disorder. These things are very common with these patients. Probably these patients are prone to have BPS. Now coming to the examination part. So it starts with a simple thing. Patient is entering into your room. You have to look over the gate. You can see whether a patient must be carrying a lot of medical records, but because this disease is still having a very, very, deficiency in awareness. That's why many doctors don't recognize this disorder, and that's why they are wrongly diagnosed as recurrent UTI or something else, chronic pelvic and blah, blah. That's why they are already depressed, and their, family members are also depressed with them, that there is no disorder, everything is in mind. So that's pretty common once patient enters. So you have to listen to the patient. This is very, very important for these patients. If you are seeing an interstitial cystitis patient, give 15 minutes extra, because otherwise probably you won't be able to do a justification. So general examination, yes, gait, mental states, somatic signs of anxiety you can see. Abdominal examination, you have to rule out any abdominal mass, scars of previous surgeries that could be lead to chronic pelvic pain, and that's retention of urine that you can see suprapubically, that probably patient is not having these kinds of problems. So pelvic examination is the most important thing, and particularly in these patients you have to look for the tenderness in anterior vaginal wall, because there is the trigone. So if it is tender on pressing over the anterior vaginal wall without doing the manual examination, if you are finding the tenderness, it could be because of the bladder pain syndrome. So it's a deep dyspareunia usually. Superficial dyspareunia usually occurs in vulvodynia and vulvovaginitis. So that's the differentiating feature. And you have to see the tone of pelvic floor muscle, because these patients, chronic patients, may suffer with pelvic floor spasm, and you have to see for the trigger points and myofascial bends as well. Neurological examination have already been covered. This is the difference. Never do bimanual examination in these patients, otherwise you might miss the diagnosis. Now, these are the summary of the investigation required to diagnose, and it is from the American Urological Association. We have modified it because we have different setup of patients. So mandatory, as you can see, only urinalysis there in addition, but with GIPS, we say that we should do ultrasound, and we should ask for the bladder ID, which is very simple to ask for the patients, from the patients. And ultrasound is so easily available in our clinics, because our patients are not very good in follow-up. So it's better to rule out many gynecological disorder by just doing ultrasound. You can even see the post-void residue. So these things are important. That's why we have kept it as mandatory. Depending on the other things, you can go for the recommendation test. Like if there is on urine routine microscopy, there is microscopic hematuria, then probably go for cytology. For even you can go for urine culture to rule out infection and other things which are written depending on the findings. And optionals are these things. So urodynamic study not required until unless there is associated disorder like overactive bladder, which is along with the interstitial cystitis. So you have to be very, and biopsy is not required for the diagnosis. It is only required to rule out other things like tubercular cystitis, which is pretty common in India. So that's why we have changed the things. We have changed the cystoscopy as recommendation, because now the new school of thought is that there are many phenotypes of this disorder, like Hunner's with Hunner's ulcer, without Hunner's ulcer. So because the treatment part might change because of the change in the phenotypes, that's why it's now it is said that it's better to do an early cystoscopy, especially if a patient is not responding to your initial treatment. So I have given already the explanation of the things. Yes, if there is history of chronic smoking, which is pretty common at my part, ladies are doing smoking, and if there is hematuria, then probably go for cytology. So this is the thing. Now coming to role of cystoscopy. This is actually a very controversial thing. The urologists are saying that cystoscopy is mandatory for diagnosis, but it's not essential actually, and at least guidelines are not saying that thing. Only once you are seeing the patient without having initial response with the treatment, then only think of the thing. And it should never be done under local anesthesia in these patients. Mind you, the patient will never come back to you if you are doing it under local anesthesia, because it's so painful for the patient. You won't be able to do additional things. If you want to do a biopsy, you won't be able to do hydrodistension. All these things cannot be done under local anesthesia, even the ablation of Hunner's ulcer, which will give immediate relief in these patients. So for these indication, it should be done under anesthesia only. So these could be the cystoscopic features. As you can see, there could be multiple things, like here at the right on the rightmost, there is an ulcer which is not good looking. These are the patients where we have to take a biopsy. Otherwise, these kinds of inflammation or glomerations, you probably don't need a biopsy to diagnose. It's a typical feature of a small bladder capacity. And I will show you one cystoscopy as well, if it will, yeah. So it's just to show, because in the last patient you have not seen the features. So just see in this patient that on initial cystoscopy you will find prominent vessels, hyperemia kind of thing, and you can see the ureters. And I told I am looking for all the walls, and gradually you will see that you can see this ulcer. So you can see the one of the Hunner's ulcer you have just, this is the second one. So this is the typical of Hunner's ulcer, which you should see without distending a bladder a lot, because later on you can see these are the mucosal tears which develop because the bladder is already contracted. These are the typical features of interstitial cystitis. And now you can see that on further distending, the patient will have starting having petechial hemorrhages, glomeration, and that is the point when the vision will be lost. So that's why you should take a biopsy or something if required beforehand. So that's the important thing. So because I have been told that already, the Dr. Jennifer is scrubbed, so I'm just concluding the things. Differential diagnosis I've already. This is the way to differentiate it from the other pathology. Just instilling the local anesthesia. If patient is having relief, then it's mean it is from the bladder. So it's not any gynecological problem. Treatment, I'm just doing a thing that you have to counsel the patient. You have to tell that it can come back. So they shouldn't have that unrealistic, thing that they will be cured of the thing. You should never ask patient for pelvic floor exercise, especially if they are having a spasm. rather reverse Kegels or pelvic floor relaxation should be done. Diet modification has specific role, and you can actually refer to our GIPS website to see the treatment parts in detail. All the acidic food should be avoided, and chronic pain, that is the most important thing. The first part should be pain relief. Any painkillers should be, you should start with the milder ones, should be included, and there are a role of physiatrist who does many things like trigger point injection acupuncture to relieve the pain. And then the other treatment is depends on the pathophysiology. As you can see, you can repair the epithelial dysfunction by just giving pentosan polysulfate to these patients. You can modulate neural activity by tricyclic therapies like amitriptyline. You can stabilize mast cells by antihistaminic therapy like hydroxyzine, and then you can treat other symptoms as well. I'm skipping these slides because I'm not left with the time. And these are the, you can ask me and you can go for the website to see the details. Sodium pentosan is specifically made for this problem only, and intravesical therapy, you can avoid the systemic side effects and all these things. So you can go for that. You can directly instill the medication inside the bladder. So these are the medication which have been, recommended by the AUA. Therapeutic, yes, you can have, ablate the ulcer, and hydrodistension, which I have already explained how to do that thing, is actually therapeutic role of cystoscopy. So I am skipping all the things. I think in these patients, just a last thing, that don't do for partial cystectomy in these patients, or augmentation cystoplasty is not helpful, because the other part of the bladder which is left will develop the disease. So these patients are the candidate for either whole bladder removal and new bladder, or a kind of your substitution cystoplasty or diversion. So guidelines you can go for. So this is a CUA guidelines, different phenotypes have been told. So my take home message that every patient is different. So don't go for any stepwise approach. If a patient is having severe symptoms, you can take any kind of therapy you can start with. You can start with vigorous therapy, direct cystoscopy as well, if patient is suffering for last 10 years. So don't go for any systemic approach. You can combine the treatments, and multimodal therapy will help the patient more. So don't feel shy to take a help of psychiatrist, neurologist, or even a urologist. Thank you so much.
Thank you for cooperating, ma'am.